Well, first of all, I wish to thank the ISPN for providing us with such excellent updates. I'm sure that we all benefit from this. And I'll shoot right off with the topic, telemetric ICP measurements in children. I have no disclosures. The agenda for my talk is to touch on some technical and practical issues, and I hope there will be time to go through some very brief clinical examples. To introduce the topic, I wish to make a few statements that we can have at the back of our minds while my talk is going on. And the first statement is that there is no ideal measurement system. So it's always a trade-off, and you always have to make a choice. You should never accept the values uncritically, but they must make sense in a clinical context. And in keeping with this, there is no system which is a substitute for good clinical judgment. You always have to have that in parallel with whatever you use. And sensors, all sensors do drift usually over longer time. So the longer they're implanted, the less reliable measurements you're going to get. And if you're in doubt of any measurement, you can consider cross-measurement in a reservoir, for instance, a borehole reservoir in the shunt or a separate reservoir. However, with these rather many precautions, I do find that telemetric ICP monitoring is very useful. We find that we can avoid unnecessary shunt surgery, that we can document shunt malfunction and secure surgery for the cases where symptomatology is ambiguous, but still are indicators of shunt malfunction. We find that we can sometimes optimize valve selection, and it's useful for shunt adjustment guidance. It's useful for assuring patient and family, and it is very useful as a long-term monitor of treatment quality. Now, before you select any kind of device and any kind of measurement situation and measurement placement, I think it's necessary to consider what kind of information you actually need. Is it important the duration of measurement you get? Is it important whether you get one or several measurements? Is it important whether you have access to night measurement, or is it acceptable with a daytime measurement or even short-term daytime measurement only? Is it important to have the option to measure in the patient's home, or is it acceptable to have just measurements in the hospital or in the outpatient clinic? Is it important to have measurements or monitoring during full normal activity and full mobilization, or is it acceptable to have just limited mobilization or even measurement during a fixed body position? And depending on your answer to these different questions, you can choose either a lumbar puncture measurement, a measurement via a conventional cable sensor. One of the available telemetric monitoring systems manufactured by Mietke, or the other commercially available system manufactured by Raumedic. Now, this talk, of course, deals with telemetric monitoring, so we're going to focus on these two systems. And as you can see, the hallmark of these systems is the ability to perform repeated measurements without new invasive procedures to be done. So I'll go ahead with a short presentation of the Raumedic system. The advantages of this is access to long-term monitoring, repeated measurements and repeated monitoring, so you can do follow-up, of course. You can compare measurements. There is the ability to measure in-house during normal activity. The system consists of the probe, implanted probe, and an external reader which you can fix to the patient, and then a data logger which can be carried even by very small children. As you can see from this mentioning of the system components, it's actually not truly telemetric because you do have to apply an external reader. And the other shortcoming is that it has a 5 Hertz sampling frequency. It's quite adequate for average ICP values and for recognition of ICP macro patterns like B waves and A waves, but it's not sufficient for individual pulse wave analysis if you should be interested in that. The major challenges of the system is actually the duration of the probe, which I'll come back to in a short while. We don't find the problem of reader fixation such a big deal any longer. If you have a nurse who's good at this, this problem almost disappears. This system is actually currently being updated and recertified by the manufacturer. So it's not commercially available for the next about 6 months, I've been told. I mentioned probe durability. This is our Kaplan-Meier analysis of probe survival, not patient survival, but probe survival. And the purple bar represents the 3 months recommended measurement period by the manufacturer. They do not guarantee signal quality or signal accessibility beyond that period. As you can actually see, many probes last considerably longer, but there is a continuous fall off. The median function period of an individual probe is actually around 200 days and not about 90 days. We found that the probe non-functionalities within the first 3 months within the purple bar were many reimplants. So we modified our procedure for reimplants not to reimplant in the exact same site if we needed continuous measurement after one probe had discontinued its function. We looked at the reasons for sensor death, and as you can see, about most of the sensor deaths was because of a technical malfunction, which was either signal loss or signal offset to considerably negative values that were sort of incompatible with the clinical situation. Less than half of the situations were patient-related factors like skin erosions or infections or allergies, or the patients or families wish to explant the device. Our periods for clinical use are, so this is sort of like looking at how long did we measure and how long did we find measurements via such device useful. And as you can see, most of the patients, for most of the patients, the period of usefulness was below 6 months. But if you sum up, the other 50% are beyond that, and there was actually a considerable number of patients where we found it useful beyond 1 year. Most measurements were 1 to 5 for each patient, but there were patients who had considerably more measurements than that. Our main indications were hydrocephalus, shunt adjustments, diagnostics, shunt replacements, questions about shunt function, and IIH, which is in keeping with a recent review looking at the currently published papers on telemetric ICP monitoring. This is just a short screenshot showing what it might look like. There's a tracing above, which is just a trend tracing, giving you no pulse wave details. But the interesting part is the one below, which is a distribution of ICP values over 24 or 48 hours. And you can see a bimodal pattern with a daytime hump and a nighttime hump, and this is actually a case of over drainage, where you have the median daytime values around -15 and the median nighttime values around 0. So the system does give you some sort of, shall we say, a simple distribution graphics to assess the median ICP values over longer time periods. Now switching to the other type of system, which is provided by Mitke. It also consists of 3 items. The implantable probe, which is integrated into the shunt system or needs access to a CSF space. It has an external reader, which is sizable, and it has a reader or a data logger component, and these are connected via a cable. As you can see, you apply the external reader at some distance to the patient, where it collects the signal, and then you get the signal or the data registered on an SD card, which is inserted into the device. You can choose between 3 types of data collections: a point measurement, just a momentary measurement shown at the left, a measurement showing just mean ICP values shown in the middle, and at the right side is a sampling, a fast sampling modality with a 40 Hertz sampling frequency, which actually gives you access to individual pulse wave analysis if that should be necessary. Now, of course, again, the advantages of this system is that you can measure repeatedly. The duration of this system is, sorry about that. Irritating. I'm sorry about that. The advantages is a repeated ICP follow-up. The duration of the chip is 3 years and not 3 months. As it is meant to be integrated into a shunt, it's the first step towards an intelligent shunt. As I mentioned, 40 Hertz sampling frequency. And you can puncture the reservoir and directly cross-check with a needle puncture measurement if you wish. As with the other, it's not truly telemetric. It's not attachable to the patient because it's sizable and it needs a distance for measurement geometrics. So it means that in practice it's not applicable for home monitoring. The device requires CSF contact. And I find the major weakness is that you need to insert a memory card to measure. And this memory card is individual per patient. There are some data storage issues and patient safety issues around this. The design is also rather bulky, which means that it's not very good for small children. Very briefly, a few examples. If you have patients with atypical symptoms, and the question is ICP mismanagement, like in these 3 shown cases, you can sometimes confirm that ICP mismanagement is in fact present, although the symptoms are atypical. In these situations, you can use both types of systems to guide shunt adjustment or shunt replacement. But as a minimum, I recommend that you make a measurement supine and upright. Otherwise, you might miss symptoms of overdrainage, which need to be corrected. If you have considerable comorbidity in terms of mental retardation, other neurological deficits, autistic features, and so on, where communication skills are difficult, you can also use both symptoms to guide shunt adjustments and to guide whether you have achieved a satisfactory ICP. We generally find in these difficult cases that monitoring, which gives you more data, will provide a better situation. For IIH, of course, monitoring over time is useful. So maybe the telemetric system for short measurements is not so useful here. If you wish to provide nighttime monitoring, which is sometimes the only pathologic pathological measurement you get in these patients, and also to guide long-term pharmacological treatment, shunting, or even sometimes shunt removal. So with these words, I conclude my speech. Thank you very much.
Thank you, Marianne. A very detailed overview. My experience, we've had a lot of problems, particularly with the Raumedic device of fracture and mechanical failure of the device. Have you got any tips for implantation that may reduce that problem occurring?
Fractures? I haven't had any.
Well, just malfunctioning once they've been implanted. They're not
Yeah.
breaking, but early failures.
Yes. Well, actually, as I said at the beginning, no system is perfect, and we also have failures that occur even within the company guarantee period. We also have had some signal loss even very shortly after implantation. I don't know how to secure this. I can recommend to make a measurement before implantation, just to make sure that the implant actually does produce a signal in free air. And I would recommend, if it's a reimplant, not to insert it into the same place. But other than that, I don't actually know.
And one live question: is it CE marked for children in the European Union? The devices, I think they are, but
if they're applicable in children,
yeah.
Well, yes, they are. I didn't show this slide, but we've used telemetric devices in kids from about 6 months to almost adulthood, to 18, and of course they're applicable in adults also. The device from Mitke, although they've made some changes to it and made it a little flatter, is still very bulky, and I wouldn't use that in very small children, and a number of patients actually feel a discomfort from the quite bulky reservoir. So I find if that is an issue, the much flatter device from Raumedic is preferable. But again, it's a trade-off whether you want a less bulky reservoir or a flatter reservoir, whether the probe durability guaranteed by the manufacturer, or whether integration into a shunt or a separate device, whether these are issues for you. And this can vary a lot from patient to patient.
Okay, thanks.